Hi, this is Yuko. We're going to do lecture number 2 about assessments. So the objectives, you can read these. The purpose of doing an assessment is to give us an accurate picture of what the client's current situation is as we admit them to the hospital. We want to look at their emotional state, mental capacity, and behavioral function. It also helps us to be able to develop an appropriate and adequate plan of care and gives us a clinical baseline in which we can use to be able to measure the outcomes of the interventions that we plan. So, factors that influence our assessing the patient, most certainly the patient's participation and feedback, right? If you have a patient who's a poor historian, you're going to have a difficult time being able to do an adequate and appropriate assessment. So in that case, one of the things you can do is try to rely on family or friends to be able to give you the information that you need. The client's health status, how are they feeling right now? Are they acute? Are they chronic? What's their ability to be able to participate in the assessment? Do they have negative experiences in their history as far as obtaining their health care? Or do they have misconceptions? What's their ability to understand, especially somebody who speaks a foreign language? So you may have to get one of those little interpreter things so that you can have somebody help you to be able to get the information that you need from the patient. And then, most of all, your attitude and your approach. Because I can tell you that I have seen patients react negatively to somebody who has a negative response to them, and it's just downhill from there. So try to be as positive, as supportive as humanly possible. And I can tell you that sometimes in psych, that can be kind of difficult to do. But be as supportive as you can. Remember that your judgment and your opinion does not matter in the nursing field. So the environment should be private, it should be safe, it should be comfortable. You don't want to try to interview somebody when it's freezing outside or when it's 115 degrees in the room, right? It should be quiet with very few distractions. Try to get information from family and friends, all right? But remember that that information is going to be based on the perceptions they have on the client. And those perceptions may not always be real accurate. So you've got to watch for some bias, all right? Open-ended questions are great. However, if the patient is disorganized in their thought processes and they're not real clear, then you may have to use close-end questions in which you just receive one-word answers like yes and no. So look at their history, age, developmental stage. Cultural considerations and spiritual beliefs are very, very prominent considerations when you are assessing a client, and most certainly when you develop their plan of care. All right. What is their ability to engage actively in their hygiene and grooming activities? Are they dressed appropriately? What's their posture like? Are they standing upright or are they standing with their shoulders slumped? Okay. Be careful with eye contact. You do not want to make eye contact with somebody who's paranoid, and you don't want to hold that eye contact because they will perceive it as a threat. So make eye contact briefly and look away. Also, again, be real careful with cultures and eye contact as well, okay? Unusual movements and mannerisms. Do they have extrapyramidal symptoms? Are they moving around slowly, which is the psychomotor retardation? The automatisms is where they look like a robot. Is that the way that they're moving? As far as speech, what's the cadence of their speech? What's the pitch? How loud is it? Are they doing things like neologisms? Neologisms are vocabulary words that are made up and only understood by the patient. A lot of times you'll see twins using neologisms. They make up a language that only the two of them understand. So what's their thought processes? Are they circumstantial, delusional? Do they have flight of ideas and ideas of reference where things just kind of fly by quickly? Ideas of reference, a good example would be my friend owns a nail shop where I get my nails done, and she's from Vietnam. And sometimes when I stand up and get ready to leave, somebody will say something in Vietnamese and they start to laugh. And I turn around and they're all looking at me. And I'm thinking, wait a minute, are they talking about me? Okay, that's ideas of reference. Tangential thinking, go off on a tangent. Thought broadcasting occurs when the patient is watching TV or listening to the radio and they think that the radio or TV is picking up their thoughts and actually broadcasting out to the public. All right. Thought insertion is where they think that you're inserting your thoughts into their head. Thought blocking, they talk and it's like they lose track of what it is that they're saying. And then, of course, withdrawal, social withdrawal. You all know what the symptoms are with that. And word salad, nothing but a bunch of words thrown together, just like you would toss a salad. So what's their mood? Okay, are they blunted? Are they inappropriate? What's the safety? Do we have to pay attention to the fact that the patient may be suicidal? Do we need to put them on a one-to-one? Or is a Q15-minute check appropriate? Is the patient feeling homicidal? Is the patient hallucinating? Are they confused and disoriented and maybe wandering into somebody else's room? So those are all safety things that you need to assess. The duty to warn is also known as the TARASOF, TARASOFF, TARASOF Act. Decades ago, there was a young co-ed at Santa Barbara State. Her name was Tatiana Tarasov, and she was involved with another student, and it did not end well, and he was quite angry with her. So he went to his counselor, and he threatened to stab her. So the counselor, in due diligence, went to the campus police and told them, hey, you need to know that this kid came to see me, and he has threatened the life of Tatiana Tarasov. Excuse me. So when campus police went and spoke with him, he said, well, yeah, I did, but you know what? I was mad and, So they went back to the therapist and they said, we talked to him and it's good. You don't need to worry. Well, then 2 months later, he does get a knife and he does stab Tatiana Tarasov to death. When the Tarasov Act was first put into place, it pertained to prominent public officials, such as judges, who get threatened all the time. Nowadays, anytime a patient comes into a behavioral health unit and they are threatening the safety of someone else, you must initiate what is called the duty to warn or the Tarasov Act. Most of the time, it's not going to be done by a nurse. It will be done by the social worker or the physician. But make sure if a patient threatens to harm someone, that you notify the appropriate people so that the Tarasov Act can be put into place. So what happens is that when the patient threatens somebody, that person who's being threatened is notified by the hospital that the patient is threatening their safety. They have a right to make sure that they secure whatever means is necessary to ensure their safety. Doing the duty to warn or Tarasov Act is the only time that you can violate HIPAA. If the patient is still feeling homicidal and threatening this individual when they are discharged, you must notify the intended victim of the date and the time of the discharge so again, they may make reasonable accommodation for their safety. So what's their sensorium? What's their level of orientation? How's their short-term or long-term memory? Can they focus and concentrate? How's their abstract thinking? Sensory perceptual, are they hallucinating? Judgment, do they have good judgment, limited judgment, poor judgment? All right. Do they tend to be impulsive or do they stop and think things out? Self-concept, how do they feel about themselves? How do they see themselves? What are their current roles socially and also interpersonally? Okay, are they addicted to things like online activities and social media? Um, how are things in the family? How are the family dynamics? All right. Then you're going to take a look at their patterns, eating, sleeping, any health problems, use of drugs or alcohol. Okay. What's their cognitive functioning like? Intellectual functioning. All right. Do they have impulse control issues? Are they out of touch with reality? Are they really defensive? Can they do things? This is called a mini mental status exam or a mini mental, and it looks at these areas, and it's used a lot of times to determine whether or not there may be the onset of dementia. I'm going to try to get a copy and upload it so that you guys can see what that looks like. So you gather all the information. Okay, one of the biggest things that we need to do as nurses is take a look at our own beliefs and gain self-awareness. We need to see what our attitude is, our opinions are about patients, certain types of care that we provide, and certain patient issues such as drug and alcohol addiction. And we need to be able to work through any negative feelings that we may have, because again, remember that our opinions and judgment, or our opinions mainly, do not belong in the nursing process. All right, we treat all patients equally and we accept them equally as well. All right, so if you hold on, I will get to the next PowerPoint. I guess I won't get to the next PowerPoint. I lost it. Okay, so when we talked last week, one of the things I said was that I was going to take it easy because it was the first day. There was a lot of confusion. So I'm going to include the vocabulary and so forth, and talk about some therapeutic communication. I think one of the biggest issues in behavioral health um, is how do you talk to a patient? All right. Because they are psych patients does not make them any different from any other patient. All patients are psych patients. So how do you talk to them? Right? It depends upon the person, right? Okay, here's your lecture objectives. So let's talk about relationships. A relationship that is symmetrical is equal. So it's between friends and colleagues. One that is complementary has a difference in status and power, such as the relationship between myself and my boss. So in 1960, there was a gentleman named Berlow, and he wrote a communication model. He stated that there has to be a stimulus where somebody is trying to communicate, a person who is sending the message, which is the sender, and of course, they can use different types of methods to send that message, such as media, like they can call you, auditory, they can send you an email, right, visual, um, or any combination of any type of media. The problem that we have nowadays in not doing face-to-face is when we send things email, we send things through text, oftentimes there's, because of the lack of emotion, the person receiving it may read that message predicated on their emotional state at that moment, and messages can get really misconstrued. All right. Also, we all perceive things differently. So their perception may be totally different than my perception, and what I'm trying to convey to them may not be the same thing that they perceive. All right. So Berlow also said that the person receiving the message is the receiver, and the response is done by feedback. Hildegard Peplau said that communication processes are guided by clarity, which ensures that the meaning of the message is accurately understood by both parties, but we know that's not always true. And continuity, because it promotes the connection between the feelings, events, and themes that are conveyed in ideas. So, what about proxemics or distance in communication? Well, nowadays, because of COVID, it's anywhere from 6 to 12 feet. But pre-COVID days, intimate interaction between individuals was about 0 to 18 inches. Nurse to client is about 3 to 6 feet. Personal was 18 to 36 inches, social 4 to 12 feet, and public 12 to 25 feet. Nowadays, though, if you stand 12 feet away from somebody, it's kind of hard to communicate with them, right? Especially if you're trying to relay something that's private. All right, so let's talk about touch. Never, never touch a client without asking their permission, especially if they have a history of trauma, all right? So this really is pertaining to things like when you go to get vitals, maybe you're going in to draw labs, or you're doing some sort of personal care, or even as simple as trying to comfort somebody, reaching out to touch their hand to convey comfort. Always ask their permission before you do it. If you have somebody who's paranoid, do not touch them at all right? Or somebody who's agitated, do not touch them. The client is not to touch you, because oftentimes there's a misperception as to what that touch conveys. And the patient may be touching you for the wrong reason, and you innocently think it's nothing. But to the patient, it means something more significant. All right. So, you can, on the opposite, you can perceive a touch as being comforting, but the patient may not. Okay. All right. So, communication basics. Be non-judgmental. If you're judgmental, it's going to shut down communication. Establish trust. If you offer yourself, which means I'm here to listen to you, I'm willing to talk to you, I'll be back to check on you in 2 hours, then that's what you better do, okay? Because if you offer yourself and you don't follow through, then that does not do much to help with the trust. Be empathetic, walk a mile in their shoes, not sympathetic, giving pity. Use active listening, be in the moment, all right? Sit there, nod your head, acknowledge, okay, but don't sit there and fall asleep or draw pictures, so forth. Be accepting and supportive of the client's feelings. Let me tell you, sometimes that can be very difficult. When that happens and I cannot be accepting or supportive, I just remain quiet. I don't say anything. All right. Clarify. If you're not sure about what is being said to you, clarify it, because there's nothing worse than you going off with half the information that is incorrect and drawing a conclusion with that. And be very matter of fact. All right, so things that can affect communication, emotional, social factors. So let's say that I get up in the morning and I have a fight with my dog. Do you think I'm going to be in the mood to listen to anybody? Most certainly, or to give any type of lengthy explanation to anyone? I don't think so. Cultural, we talked about that. Language differences, we talked about that. Use an interpreter. It's best if you can to get an interpreter who is not a family member, because family members oftentimes have emotional connections. And I don't know about you, but in times when I've used family, and I understood things like Spanish, what I have said came out totally different than the interpreter's presentation to the patient. So it's not always accurate, okay? Lifestyle differences, don't forget to consider cognitive factors. Do they have any long-term, short-term memory impairment, all right? And also physical things. Can they see well? Can they hear well? I don't know about you guys who wear glasses, but I can't hear very well until I have my glasses on, because the senses all work together, all right? And then societal factors. Are you talking in a room that is real crowded and noisy? Are there a lot of people? Do you have any privacy? Okay, remember that communication is 10% verbal, 90% nonverbal. Okay, the spoken word represents your public self. The nonverbal covers a wide range that includes things like body movements, responses to the messages of other. Be real careful with facial expression because patients do watch your face. All right. Be careful with body language. When you sit down and you cross your arms, that's a closed body posture. And that means basically, I'm not interested or I'm not willing to hear you. Also, when you cross your legs, you cross your knees, that also indicates that you're closed off. When you sit down to talk with a client, I always recommend that you sit at a table, put your hands on the arms of the chair, or put them up on the table where they can be seen at all times. Don't put your hands underneath the desk or the table, because if you're fidgeting, the patient's going to wonder what it is you're doing under there. When you approach a patient, don't walk up with your hands behind your back, because I'm an old nurse. I was taught to carry my injection syringes behind my back. Don't put your hands in your pocket, because again, they don't know what you have in your pocket. All right. You should be standing with your feet shoulder length apart, and you should have your hands out by your side, palms facing upwards. Okay, so areas that might be problematic. We all communicate differently. Some of us are very succinct. Some of us tend to be more in depth. Use of eye contact, again, Native Americans, Asians tend to have no eye contact. We tend to look away. So don't forget, when you document eye contact and it's cultural, then document eye contact appropriate for culture. All right. Perception of touch, please, again, don't touch a patient without asking them, and don't let them touch you. And then culture. In some cultures, it's okay for a man to take care of a woman and a woman take care of a man. In some cultures, it's not. Remember that things like a smile does not mean the same thing in all cultures. So the difference in communication styles in diverse populations can be kind of daunting sometimes. All right, and that's where it helps to be able to have the link with the interpreters. All right, again, cultural meanings of verbal and nonverbal communication, the ability of the interpreter to speak and understand English as well. So you need to get somebody who is quite proficient in the language. And then again, attitudes and beliefs. Be real careful about any negative beliefs or reactions. All right, so active listening. Sit there and listen to the patient. All right, give them your undivided attention. All right. Oftentimes, when patients are talking to you, especially if they are psychotic, you may feel confused or uncertain, and that's an okay thing. Use things like clarification, and what you can say to a client is, excuse me, but I'm not sure if I heard you properly, but this is what I think you said to me. Is that appropriate? Or is that, what you're saying to me? All right. All right. Some therapeutic communication skills, using broad opening statements, okay? General leads, exploring, saying things like, I'm really interested in talking more in depth about that. Could you tell me about? All right. General leads, go on. I'd like to hear more about that. Wow, you went on vacation? That sounds great. All right. Be very careful about using silence, especially with somebody who is paranoid, because the silence will feed into the paranoia. All right. Being accepting conveys positive regard, giving recognition. Sometimes patients do some things that are just remarkable. And there's nothing wrong with saying, wow, how did you get through that? Tell me what your techniques were, or tell me what skills you used to be able to resolve this issue. Okay, we talked about offering self. Direct approach, again, if you have a patient who is suicidal, psychotic, you're going to want to ask them yes or no questions. Okay? Are you feeling suicidal? Are you hearing voices? Okay? Acknowledging what the patient has done without using your judgment. Okay? Clarifying, making sure that you're hearing what is being said. Encouraging, if the patient is hallucinating, please ask them, are you hearing voices? If the answer is yes, then the next question should be, what are the voices saying? And I'm going to tell you why, because it's a safety thing. I one time saw a patient and I was wearing a Polynesian print scrub top, and the patient was stimming. He was listening to a voice, and I asked him if he was, hearing voices. He said yes. And when I asked him what the voices were saying, he said, the voices are telling me I need to kill nurses who wear Polynesian scrub tops. So that means time for me to make like sheep and get the flock out of there, right? Okay, information giving, you seem anxious. Okay, you seem tired. You seem distressed. All right. Open-ended questions are things that don't require just a yes or no. Instead of saying, did you like breakfast this morning? What about it did you like for breakfast this morning? And watch the word what too. I'm horrible at that. Okay, reflecting, restating. I often don't do that because the patient may feel that you may be mimicking them or belittling them. Okay, we talked about silence, suggesting. Have you considered? Have you thought about? Maybe this might help. All right. Helpful phrases. Okay, I'd like to discuss what you're thinking. What are your thoughts? Tell me about things you don't want to say. My big pet peeve is I know how you feel. Because no, you don't. They're my thoughts and my feelings. They have nothing to do with you. Okay. Another one, if it were me, I would. Oh no, we're not talking about you. We're talking about me. All right. Yeah, I like that one too. It's the policy of this unit, and I'll tell you what to do with your policies too. Just a second. Oh no, pay attention to me now, right? All right. Giving reassurance. Be real careful about giving reassurance. All right, because a lot of times you don't know what to say, and you want to say what you know the patient wants to hear. Or just because you don't know what to say, you give them those kind of generic answers. Oh, no, it'll be okay. It'll all work out. Well, what if it doesn't? Okay. Be real careful about giving advice. Um, I always turn it back on to the patient. If the patient says to me, well, what should I do? I say to them, well, tell me, what do you think you should do? Or what does your family think you should do? What do your friends think you should do? What does your clergy feel you should do? All right. I don't ever give them a direct answer to that. So, all right. Be careful about asking why or what questions because it can imply that the patient has to defend their behaviors. Don't give incongruent messages. Those are messages that don't match. All right. Be careful about interpreting again because we all have different perceptions about things and you don't want to misinterpret something. Okay. I don't know what happened to body language, but be careful with your body language with patients. Okay. All right. Let me get to the other lecture. Therapeutic relationships. All right, here's your lecture objectives. You can read those when you get home. So relationships are goal-oriented. There's 3 different types: social, intimate, and therapeutic. The only ones we're really interested in are going to be the therapeutic ones. You have to have rapport, positive rapport. If you can't have rapport with the patient, don't even try to engage, because it's just not going to work. I think we've all kind of met somebody for some odd reason. You just don't like them when you meet them. So, yeah, if that happens, then don't even bother. You have to be able to have trust in each other. The problem is, a lot of times patients will tell you all kinds of stuff. Make sure you check it out before you believe it, okay? Always, always be respectful. Again, very big about respect of patients, also of yourself. If you don't have any self-respect, you're not going to be able to respect anybody, all right? Be genuine. Be there in the moment. Please don't just give them those pat answers. Oh, yeah, okay, yeah, whatever. It'll be okay. That's kind of a worthless type of communication, right? Be empathetic. So, our nursing roles. We are teachers. That's a real important role. We need to educate our clients about their medications, about their disease process, and so forth. We are caregivers as well, hands-on. That's what nursing is about. Okay, not sending somebody else down there to do the care, but putting your hands on the patient, taking care of them. I mean, that's why we all became nurses. One of the biggest roles, advocate, especially with patients who cannot advocate for themselves. Let me tell you, in your role as an advocate, you may come across situations that are going to be very difficult for you to be an advocate for your patient, especially if there's a lot of negativity surrounding your role or what it is that you're advocating for. And we do become surrogate parents to a lot of patients. I'm old enough that a lot of people think I'm their grandmother. Yay. So they talk to me about things. Um, that's a very great honor to have somebody who trusts you that much. All right, so phases of a therapeutic relationship. Pre-orientation phase, where you find out about the patient, or you go to their chart and you look up the information about them. All right, and then you look at your own feelings. Am I going to be afraid to work with this patient? Do I feel comfortable working with this patient? Do I like what they've done? Do I not like what they've done? So you've got to look at how you feel about what it is that you're going to do with the patient. Okay. So orientation phase, you create an environment for trust and rapport. You're going to identify strengths and weaknesses of the client. And then you're going to establish a contract for intervention. You're going to constantly reassess the progress of that contract, okay? Because sometimes things just aren't going to work, and you've got to be able to know when to throw in the towel or when to do something different. All right? You make your nursing diagnosis. Now, in psych, we can use the words risk for and potential for in our nursing diagnoses. All right? There has to be goals that are realistic. All right, because if you don't help the patient set up realistic goals, then you're going to help them to set themselves up for failure. All right, and again, explore the feelings of both of you. So in the working phase, overcoming resistance behaviors, I call that yes, but. So you have a patient who is stuck in their ways, and you want to try to give them some new coping skills. And you say, so instead of getting intoxicated, have you thought about trying this? Yes, but all right. So instead of going out and getting intoxicated when you get in a fight with your wife, have you thought about exercise? Yes, but okay. So when you get those yes buts, they can be very, very difficult to overcome. Use problem solving. What worked before? Okay. When you were in a situation similar to this, what did you do? How did you do it? And then always look at your attainment of your goals. The termination phase of a relationship begins at the beginning of the relationship. All right. So when there's a failure to progress, it's time to change the relationship, right? Think about the relationship between all of you and me. We already know that in 4 weeks, our relationship is going to end because I will no longer be your instructor. I hope it goes on for much longer than that. However, as your instructor, that's when it will end. So let's talk about transference. That's where a patient sees something in us that reminds them of somebody else. So they can be angry, they can be hostile, or they can really love us, okay? If transference occurs, you need to switch patients. If it's bad enough, you may need to switch units. Countertransference is where we do it to the patient. So I may be working with somebody and I don't like them because they remind me of my brother who was a pain in the neck, and I say to the nurse, hey, can we switch patients? Because I can't stand this guy. He reminds me too much of my brother. All right, so switch patients or you may need to switch units. All right, that was a quick one, right? All right, let me get to the vocabulary. All righty. So, did I miss a slide? Okay, there's your lecture objectives. Okay, now I scooted everything over in the slides, so you'll notice they all seem to be jammed up to the right because they were cutting off in the left-hand side, and that just drives me batty. So a 24-hour notice is where a patient is requesting a premature discharge. They must put it in writing, and they have 24 hours from the time the form is signed. However, the bad thing is that a 24-hour notice is not effective on the weekends or on obscure holidays like Columbus Day. So when a patient gets ready to sign a 24-hour notice, I will tell them it's not going to be effective on Saturday or Sunday, and Monday is Columbus Day, so you're not going to be going anywhere until Tuesday. All right? Because I will guarantee you, if they sign that form on Friday, on Saturday morning, they get up, they think they're going home, and when you break it to them that they aren't going anywhere, there's going to be a fight, right? The affect is the outward presentation of their feelings or emotions, can be described as flat, blunted, restricted, guarded, suspicious. AIMS, abnormal involuntary movement scale. You will need to remember this. All right, when we get to the extrapyramidal symptoms, the AIMS is going to play an important part in your assessing the patient for any type of EPS, specifically tardive dyskinesia. All right? Altruistic, doing good for others, or altruism, okay? Personality disorders such as borderline personality disorder, antisocial personality disorder cannot be altruistic. They cannot do good for other people. So ambivalence, two opposing emotions. You love it, you hate it, you want it, you don't want it. Okay? Auditory hallucinations, where you hear sounds or voices. BAD, bi, two, polar, poles, affective disorder. So that's somebody who's considered to be manic depressive. Okay? BAL, BAC, or BA, blood alcohol level, lethal level is at 400. The CINA Clinical Institute Narcotic Assessment is for opiates. The CIWA Clinical Institute Withdrawal Assessment is for lorazepam detox and also for alcohol. Okay. CM is a case manager. CMI is chronically mentally ill. Congruence, emotions match statements. So let's say I'm a patient and I wake up in the morning and I come out and I'm like, hey, good morning, how are you? And you say, Yuko, how are you feeling today? And I go, you know what? I am so depressed. My verbalization is incongruent with my emotions, right? Because I'm telling you I'm depressed, but I'm real exuberant. Okay? COT, court ordered treatment. That means that a patient previously may have was on petition and went to court and they were put on court ordered treatment. The length of time for a court ordered treatment is usually 1 year. DO is disorder. We don't have diseases in psych, we have disorders. DD that should be changed actually to ID because it's intellectually, developmentally disabled. Okay. Depot or deconduit are also known as LAIs, long-acting injectables. They are antipsychotic injections that are given IM. They last about 2 weeks, up to, I believe now, 3 months. They activate in approximately 36 hours. And we will cover that when I get to the pharmacology thing. DID, dissociative identity disorder, used to be known as multiple personality disorder. Pretty interesting. Okay, you will need to remember this term, DTO, danger to others, wanting to hurt someone. DTS, danger to self, you'll need to know that one as well. So a patient who's homicidal or is DTO, a patient who's suicidal is DTS. All right, you will need to remember this one too, dual diagnosis. That's where they have the chemical abuse and a psychiatric disorder. ECT, you'll need to know electroconvulsive therapy or shock therapy. You'll also need to know EPS or extrapyramidal symptoms or movement disorders. Okay, ETOH is alcohol. FOI, flight of ideas, they fly from one topic to another. The GAF, the Global Assessment of Functioning, is kind of going by the wayside, I believe. The higher the number, the better the level of functioning. We as normal people have a GAF score of approximately 80. Okay, GD, you will need to remember, is gravely disabled. HI, also remember, homicidal ideations, wanting to kill someone. Hyper-religiosity is where they're fixated on religion, and they literally will walk around the unit with a Bible quoting scripture. Usually around Christmas time, we get Jesus on the unit. We also get the Virgin Mary. Hypervigilance, oftentimes seen with patients who are paranoid and suspicious. Okay, so they watch everything and they listen to everything. Hypomania, right on the threshold of going into full-blown mania. I like it when they're hypomanic. They tend to be very literal. I had a patient one time who was hypomanic, and she came up about 3 o'clock in the morning, and she comes up to the nurse's station, knocks on the window, and she says, "Hey, so in the morning I think I'm going to have bacon and eggs for breakfast, and I think I want one of those muffins. And you know what? I don't think it would hurt if I had a bowl of oatmeal." And I said, "Shh, lower your voice," because she was talking real loud. And she went, "Okay, I think then maybe I should also have milk." So they tend to be very literal. They are constant, move, move, move. You just can't slow them down. But they tend to be that way for about 3 to 4 days, sometimes 5 days, and until they actually drop from exhaustion. Okay, LOA, looseness of associations. That's where they also shift topics, but there is a thread that ties them together. MDD, major depressive disorder. NOS, not otherwise specified. So that would be like me telling you that I'm going to give you a patient who is diabetic. Is it insulin dependent or non-insulin dependent? Okay. OCD, obsessive compulsive disorder. PAD, persistently and acutely disabled. Please remember that term as well. Petition. So let's say the patient has done something to make them petitionable. Anybody can be a petitioner, but you have to have firsthand information or knowledge about the grounds that make the patient petitionable. Those grounds are danger to self, danger to others, gravely disabled, and persistently and acutely disabled. If a patient is found petitionable, then they can be placed on an involuntary 72-hour hold, and they are evaluated within 24 hours by a psychiatrist, and it has to be stipulated or agreed upon by a second psychiatrist. And that second psychiatrist may be somebody that the patient pays for out of pocket. So the two psychiatrists need to either agree to keep the petition in place or to drop the petition. If the petition is dropped, then the patient becomes voluntary. If the petition stays in place, then the patient has to go to court. And usually that's within 7 to 14 days. Then A judge is there. The patient can have a full trial. There is an attorney, two attorneys, patient's attorney, and then the prosecuting attorney. Any witnesses that have firsthand knowledge of what makes the patient petitionable are called. The patient can also call their own witnesses, and they can have a full-blown trial. If the patient is found to be placed on court-ordered treatment, again, it's usually for a period of a year. They also lose their right to bear arms. So they cannot purchase a firearm, and it's a right that they have to have restored by petitioning the court. So their Social Security number is given out to the Department of Public Safety, so they're not able to buy any type of firearms. And actually, under court-ordered treatment, a patient does not have the right to refuse medications. If a patient is called, if they are petitioned or they are voluntary, they have the right to refuse medications. If a patient behaves themselves and their court-ordered treatment was dropped, but let's say they miss taking their medications or they miss their doctor's appointment, that court order can be put back in place or called revoked or revocation, and the patient will be put back on court-ordered treatment for a year. And again, they will not be able to refuse medications. Okay? If a patient is in the hospital and they're on court-ordered treatment and they refuse their oral medications, you have the right to be able to hold them down and administer an IM against their will. All right? But we'll talk more about that. Proxemics, your personal space. We as Americans like about 3 to 5 feet. Right now, it's more like 6 to 12. PSA, post-suicide attempt or polysubstance abuse. RCOT, the revoked court-ordered treatment. I know revoked means taken away, but in this case, it means put back. Okay? What's taken away are their civil rights. SI, suicidal ideations. SMI, seriously mentally ill. Stimming, where you hear voices or noises and you respond to them. So think about the patient who's talking to themselves. All right? Tactile hallucinations, where you feel bugs and pins. Okay, we talked about Tatiana Tarasov and the duty to warn. Visual hallucinations, where you see people, demons, etc. So let's talk about the system here in Tucson for the mentally ill. It's what's called a REBA, Regional Behavioral Health Authority, and they are the gatekeepers of the money that takes care of the mentally ill patients. There are clinical sites, Kodak, Cope, La Frontera. They all have case managers. Those case managers have a caseload of about 250 patients. So needless to say, a lot of patients get dropped through the cracks. There is a psychiatrist, one or more psychiatrists at each site, nurse practitioners, psychiatric nurse practitioners, and about every 3 months the patients go in and see the psychiatrist or they see the nurse practitioner and they get their medications ordered through them. The medications are covered through the sin taxes. When you consider that one dose of Geodon, which is an antipsychotic, at 30 milligrams daily is about $750. It is not cheap. All right? So the patient goes, they get case management, they get therapy, they get seen by the psychiatrist or the nurse practitioner. So they have to keep those appointments if they're court ordered. If they fail to, then they will be revoked. All right, so this is the psychiatric taxonomy. Access 1 are your clinical disorders, such as schizophrenia, major depression. Access 2, personality disorders, so borderline personality, antisocial personality, or what's still called mental retardation, or IDD. All right? Access 3, general medical conditions like CHF, COPD. Access 4, psychosocial and environmental. Now, the thing you need to know about Access 4 is that the evaluator doing the evaluation, remember that this is purely subjective. So let's say that Joshua is driving to school and he gets pulled over and he gets a ticket. And he walks into class and he's really upset because he got this ticket. And I say, what's going on? Man, I am so ticked off. I got this ticket. You know, And I said, okay, so on a scale of 1 to 10, with 10 being the very worst, how severe would you say this impacts you? Oh man, not even 10, maybe a 15. And I said, okay, well, how fast over the speed limit were you going? 2 miles. Inside, I'm going, what? 2 miles? On a scale of 1 to 10, he gives it a 15. No, I think maybe it would be a 2. So that's how it can be subjective. All right. So under this axis, we look at legal problems, relationship difficulties, etc. Axis 5 is the global assessment of functioning. Remember that the higher the number, the better the level of functioning. And if you do have a GAF, and usually there will be a comparative score, like the GAF today is this, and the GAF a month ago or 3 months ago was this. Okay? All right, and this is what it's going to look like when you look at a patient's history and physical. All right? And I believe that is it. So if you have any questions, we will discuss it during class when I see you on Wednesday. All right? So I'll talk to you later. Bye. Thank you.